Hello everybody and welcome to our COVID-19 question time. You're all very welcome. We'll just wait a moment or two as you log in and join. But thanks for signing up for the webinar today. Okay, so it's now 5 o'clock. I hope that everybody can hear me. A big welcome again to all of you who are joining our COVID-19 question time webinar this afternoon. You're very, very welcome. And what we'd like to do is just kind of take you through a few things. So first of all, this is if you're on Twitter, you can tweet about it using the hashtag COVID question time. And if Julie could just pop on to the next slide, please, we'll just talk a little bit about how it's going to run. Now, a few of you have been in touch asking about subtitles, so we will be sharing this webinar on YouTube in a couple of weeks' time, or hopefully sooner than that, and there'll be subtitles available there. So during the webinar, feel free to post your own questions to the panelists. If you look at the bottom of the screen, you should be able to see something called Q&A. So that's where we'll be looking for your questions. Some of those we'll answer live and some of those we'll try to pick up at the end if there's time. We'll see how that goes. We've had the most enormous number of questions from you, which is absolutely great for today. And if you have any technical questions, please put them in the chat. And somebody just said that it's very quiet, and I just wonder if I turn myself up, if that's helping. Is that helping? Because we were okay on technical checks before.
It may be worth leaving and rejoining if you can't hear.
Thanks, Julie. Okay, so please let me know if you can't hear. I have turned myself up a lot. Okay, so thank you for using the chat for the technical issues, because that's what they're there for. You can upvote anything that comes up in Q&A if you're particularly interested in the answer to those questions. And as we've just said, we are recording this meeting so that we can share it subsequently as well. So no further ado, I'd like to go on to the next slide. And just to say, there's very little on these slides. We'll mainly be talking. So if you're looking on your phone or listening to this on your phone, you're not missing out on anything. It's merely I've just put people's names and spellings there to do the introductions. So joining us, we've got not one, not two, but three kidney doctors this afternoon. So I'm very honoured to be joined by, first of all, Dr. Rebecca Suckling. I don't know if Becky's on. Yes, there she is. There. So she's a kidney doctor and Associate Medical Director for Transformation at Epsom and St Helier Hospital. We're also joined by Dr. Andrew Frankel, who is a kidney doctor at Imperial College, NHS. He's got particular interest in the management of diabetes and kidney disease. And by the way, all of our medical colleagues have many, many strings to their bow, but I only put a couple of things in here for this introduction. And then we also have Professor Richard Haynes, kidney doctor at the Oxford Kidney Unit, and he is a part of the Recovery Collaborative Group, which is leading a large-scale clinical trial of potential treatments for people hospitalised with COVID-19. So he'll be able to tell us a bit about that as we go through. We've got Julie, who you've already heard, doing her technical support thing. And then from Kidney Care UK, there are at least three of us on the panel here. We've got Sharon Woodward, who's our comms officer, senior comms officer. We've got Samantha Sharp, our senior policy officer, and me, I'm the policy director for Kidney Care UK. And we are, and as hopefully many of you know, I am also a kidney patient. I spent 5 years on dialysis, and later in December will be my 40th anniversary of the transplant from my husband. So Let's move on then. So this is the third of our webinars. The first looked at COVID-19 and dialysis. The second one looked at COVID-19 and transplantation. And this one is slightly more general, but in the end it's become quite particular because you've asked a lot of questions about vaccines. So our questions fall into four key areas. The first one is around the impact of COVID-19 on people with kidney disease. Then you asked a lot of questions about vaccines. That's a very popular topic. Then there were some other questions about employment, and we're putting a little bit in at the end about Christmas because it's that time of the year. So what I'd like to do then is I'd like to just go on to the next slide, if that's okay, Julie, just to remind everybody that this part of the webinar, we're talking about the impact of COVID-19, what we know so far, a bit about risk, and things about treating COVID-19 as well. We've had a fair amount of questions about that, so I'd like to invite Andrew Frankel to take the floor and to start by updating us on what we've learned so far about the risk to kidney patients from COVID, and what we've learned about outcomes, and there's a few other questions about use of immunosuppressants. So I wonder if Dr. Frankel could kick us off. Thank you.
So Fiona, first of all, thank you very much for inviting me to be on this webinar, and good afternoon, everybody. Since we last were on a webinar together, which was further back in the summer, while it may seem that the COVID-19 pandemic has just gone on and on, I think we can say there's been a lot more understanding about COVID-19 and how it affects people with kidney disease. And I think there are three broad areas that have changed, where we've got greater knowledge and understanding. They include risk, which I think we're going to talk about a little bit more detail. They include how we look after people on hemodialysis. And we've all now learnt and shared from each other around the UK, and indeed from some international data. And I think how people are cared for on dialysis units has significantly altered. And I think that's having a big impact on the likelihood of picking up COVID-19 through the hemodialysis process. And finally, of course, we have moved significantly forward in regard to treatments. And I know that that's going to be covered a little bit further in the seminar, in the webinar. Risk clearly is an issue. Let's try and put this into a perspective by me telling you two things that may seem diametrically opposite. The first is COVID-19 is a serious disorder. But the second thing is, please remember, many people get COVID-19 without even realizing it. And a significant proportion of people who get COVID-19 get an asymptomatic infection. However, we do know there are a number of factors that will increase your risk. And I've urged you, I think in the summer, not to see this as what we call binary. Either it is yes or no. I have the risk or I don't. The risk is a variable, and there are a number of factors that may increase your risk. Perhaps the most important factor is age. And the older you are, the greater your risk if you acquire COVID-19. There's no evidence that you're going to be more likely to get it, but once you've got it, that carries increased risk. And then on top of it are all the other things that you may have heard about. Obesity, diabetes, ethnicity. They all play a part in increasing your risk of getting the virus and suffering more significantly, and included in that is immunosuppression. So I urge everyone to think of themselves at risk, and everyone to be taking on behaviors that would minimize their chance of getting COVID in the first place: social distancing, minimizing their time out of home, washing hands, etc. And there'll be some of you who will recognize yourself as being extremely vulnerable. Fiona, does that sort of give you a good introduction into, I think, where we've moved between now and last August?
Yes, thank you very much for that. And I think that the next sort of question that perhaps people would like to hear about is any evidence we have about how people on immunosuppressants, what their outcomes are from COVID infections, and also whether taking immunosuppressants has any impact on the so-called cytokine storm. I
think we know that COVID-19 is spreading through, as you know, aerosol. I don't think it makes any difference wherever you are on that risk spectrum, whether you're on immunosuppressants or age, in terms of acquiring it. It's your behavior and it's your environment that will determine whether you acquire it. How will you become is affected by these things, and I think immunosuppression is important. If you are immunosuppressed, you are more likely to develop significant pneumonia and respiratory problems and higher fever and difficulty in eradicating COVID-19. And that is the key issue for people who are on immunosuppression, and indeed the people who are at the end of the spectrum in terms of risk. So yes, it does mean that you are more likely to suffer this acute respiratory deterioration, have a longer period with a fever, carry the virus longer. Whether or not it makes any difference in terms of what they call the cytokine storm, and I will highlight that the management of that has altered enormously in the last 6 months. It's become less, I think, of the issue compared to the respiratory complications of COVID-19.
Thank you. Okay, that's great. Just a little bit more on that, if I may. I'm a transplant patient in my early 30s. I'm really keen to understand my risk and how scared of COVID-19 I should be. You're on mute, Andrew.
Yeah. So you use the word scared. Scared, of course, you should be concerned, you should be anxious, you should be adapting your behaviors. But actually, if you are age 30 and you have no other particular factors other than being a transplant patient on standard immunosuppression, if you pick up COVID-19, your risk of coming to significant harm is very, very much less than someone who is older, who is more obese, who may be from a different ethnicity. I'm making an assumption here about ethnicity. So your risk is not huge. But I would still urge you to think about how you protect yourself, how you try and reduce your risk of acquiring. But again, would remind you that if you've got this, it doesn't mean that this is the end of the world. It doesn't mean you're going to suffer a really significant infection. Most people of your age, even transplant patients, will get through this, many without symptoms, most with mild illness.
Thank you, Andrew. That's really helpful. And that leads very nicely into our next question, which is about shielding. And I know shielding has been quite a topic that we've all had to undergo over a period of time, and a lot of it's about protecting ourselves as well. So somebody has asked about shielding being perhaps a little bit of a blunt instrument, and how, with what we've learned now, we can use that. And this particular person was kind of talking about whether they should, in fact, they wanted to go back to work, but that some of the shielding guidance had perhaps made their colleagues extra concerned about whether they should come back or not. And then on the flip side, there's other people who are worried about whether it's yet safe for them to go back to work. So there's people wanting to go back to work and people not necessarily feeling safe about going back to work. And I wonder if you could comment on that, please.
Well, Fiona, I think this all comes down again to where you are on that risk assessment. If you are someone who is more elderly and more likely to suffer an adverse outcome, a poor outcome, then you need to ensure your social isolation is more stringent. If you take the 30-year-old who has got no other issues, then you would then consider the potential that you might be able to work in a safe environment at work, as long as your employer has made it as safe as possible and you weren't traveling public transport, busy time, you were able to maintain social distancing during your time you're going to and from. So I don't think I'm afraid this is where the problem is. Shielding, you're absolutely right, was so blunt. Everyone was taken into the same group. I think you've got to look at yourself as an individual think about your risk, think about the risk in the place you work and how that's being managed. Work with and seek advice from your nursing staff, your medical staff, to help you if you can't assess your own risk, and to help you in terms of negotiating with your employers as to what's the appropriate thing for you. So the answer is, it is a blunt instrument. Determining what you do is very much dependent on your individual, the factors around you individually and your individual risk.
Okay, great. And then seek advice from your nursing team, your transplant team, your GP if necessary. But of course, it's the kidney teams that will be the most informed about helping you with that.
Yes.
All right. So what we're going to do now is I'm going to invite Professor Haynes to speak. And we've had some questions that have come through on both the Q&A and of course and in advance as well. And these are really around treating COVID, and we also had a couple of questions about long COVID. And so I suppose if I could invite Professor Haynes just to get going with just a bit of an update there about what we've learned about treating COVID and any particular points from the recovery trial that you think would be useful for our audience to know, because there are, and just one other thing, sorry, to the audience, just to say, if you could put the questions in the Q&A, only technical stuff in the chat, that would be really helpful. Thanks, and over to you, Richard.
Thanks. So I think we've learned an awful lot since March, when this COVID first came to the UK, about how to treat it. And I think one of the things I'd probably first like to say is that because of the advances that we've made, partly through testing treatments, but also just from experience of treating the disease within the NHS, we know that the chances of people admitted to hospital ending up with a bad outcome, and by that I mean sadly dying, we know that risk has fallen since March, April time, and that it's lower now than it was then. So I think a lot of what we've learned has actually now transformed into improved outcomes, which I think is good news. So what have we learned about specific treatments? Well, if we start with treatments that people might be given if you were to end up in hospital, I think there's probably been three main treatments of interest. One, probably the first treatment to get announced, was a drug called remdesivir, which some of you may have heard about. And that appears to shorten the length of time that you would need to stay in hospital if you did get admitted. It's not a particularly easy drug to give. It has to be given intravenously. It doesn't appear to affect other things. It affects how long you stay in hospital, but it doesn't appear to affect, for example, your chances of having a worse outcome. But that was the first drug that we learned about to work. And then a bit later on, the recovery trial, the trial I work on, actually was the first trial to show a more positive result. So we found out that the steroid dexamethasone, which probably isn't the sort of steroids that those of you who take steroids are used to, but it's a common sort of steroid that given in moderate doses to people who need oxygen or who are more poorly, who are on a ventilator, we actually found that did substantially reduce the risk of death. So that is now part of standard care in the NHS and all around the world, and is contributing to the improved outcomes that we're now seeing. So that was really good news too. And then much more recently, there's been another drug reported, some of you may have heard about it in the press last week, called tocilizumab, which appears to improve outcomes for people, the most poorly people, the people on intensive care. There does seem to be some benefit of that. So those are all really important treatments. The thing about those treatments were that they weren't designed just for COVID. They were treatments that we already had in the drug cabinet, and they've been repurposed. So we've tested them in COVID, and for those three, we found some benefit. In terms of kidney patients, they've been included in some of those trials, and they haven't been included in others. I think by and large, the message seems to be that they should be treated in just the same way. So, for example, in the recovery trial, we included people on dialysis, people with transplants, all sorts of different kidney patients, and we didn't find any evidence that they benefited any differently to other people in that trial group. So I think, by and large, kidney patients should get the same treatments that other patients are being offered, providing that there isn't a a specific contraindication because of some other drug you might have to take, or your specific kidney condition.
Thank you. And I guess that would be fair to say, would it, Richard, that that would then be discussed between you and your the team who was caring for you? Were you actually ever in that particular situation?
Exactly, and they would probably in turn discuss it with your own kidney doctor as well. But yes, those decisions will be made at an individual basis.
But the encouraging thing I take from that is that there are a range of treatments. There was now some building experience on those, and we've learned a lot. And some of those definitely included kidney patients.
Yeah.
And the other thing I wonder if you can perhaps comment on, of course, that while a number of kidney patients have contracted COVID, I mean, many people have, of course, done okay and come through the other side. And I wonder if there's any comments you'd like to make about that.
Yes, I think the majority of people who get COVID, as Andrew said at the start, many of them never know about it. It's all asymptomatic. And even those people who are symptomatic, the majority of them just recover at home after feeling lousy for a week or so, probably. Even people admitted to hospital, the majority of them recover too. So I think, and that proportion is increasing. So I think there's a lot of progress has been made, and things are looking brighter, certainly, than they were back in the spring.
Thank you. And actually, if anyone wants to hear from a kidney patient who has himself contracted COVID, there's a blog about it on our website. So anyone listening want to take a look at that and hear from someone who's had COVID, that's worth checking out. Now, I wonder if we could just ask you about long COVID. Have you do we know if there are any kidney patients who've had long COVID, and do we know anything about that at all yet?
Yeah, so long COVID is harder. I'm sure some kidney patients have had long COVID. Whether it's affected their kidneys or not, I don't think we know yet. I think certainly the initial descriptions of long COVID were prolonged symptoms of feeling very tired, muscle pains, difficulty thinking. So the initial descriptions were symptom based rather than actually, and what we don't know yet is actually whether there are any long-term effects on things like how well your kidneys work or how well your lungs work. For example, if you've been very poorly with your lungs, does it leave you with long-term lung damage? We don't know we don't know the answer to those questions yet. There are studies going on which are going to look at this very carefully in the UK. So it may well be that if you have been unfortunate enough to be poorly with COVID and end up in hospital, you may get invited to take part in one of those studies. And I'd encourage you to do so, because that will help us learn, firstly, what it actually means for people with kidney disease. And then in due course, there may well be treatments that are tested, and it may be an opportunity to find out whether we've got any treatments to reduce the burden of symptoms that people seem to get.
Okay, no, that's really helpful to know. That's information I knew a little bit about that, but not at all what you just said. So that's great. Could you just one further one in this section, if that's okay, just a little bit about self-monitoring. Is there any value in people buying themselves? I think they're called oximeters, aren't they? So you can actually test your oxygen level through your finger. And at what stage, if you were doing that, would it be relevant for you to then call your kidney unit and say, oh, I'm worried my oxygen levels are going down, that kind of thing? So it's a little bit about self-management. Any thoughts you've got on that?
Yeah, so I think this might not entirely have to be driven by you, that there are increasing hospitals have what we call virtual COVID wards, where people who they want to keep an eye on but don't think are poorly enough to go into hospital, they give them an oximeter, send them home, and then speak to them each day and find out what the readings are like. So this might be something that you can do in collaboration with your hospital if you were to get ill. I think it's very hard, I'm afraid, to set absolute numbers. If your oxygen saturation was less than 92%, you should definitely go to a hospital, because everybody's different. I think it doesn't matter so much what the particular value is that you measure. It's often what the change is. That if you find your oxygen saturation is dropping, that's what should trigger you to go to seek attention, more than just what any given level might be. And in particular, how it combines with how you're feeling. Because if you're feeling worse and your oxygen saturations are falling, I would be a lot more concerned than if you told me you're feeling absolutely fine, but your oxygen saturations have fallen. So I think it's just one piece. It's not going to be the perfect thing, but it might just be one more piece of information that you might find reassuring or helpful to share.
Of course, thank you. And actually, of course, for anybody who develops COVID, I mean, don't go into your unit initially, but do ring them up and let them know that you have it, or you believe you're worried that you have it. And if you've had a test, of course, that shows you're positive, then let your unit know, and they'll talk to you about, give you your personal advice on that as well. Right. So what I'm going to do now is just go back to Andrew, if I may, for now, just a little bit about vitamin D. There's been, we've had several questions actually through about supplements to reduce my risk of COVID. Does it have any side, is vitamin D good for us? Should we be taking it anyway? And also there was some news this weekend that the government will be offering vitamin D to anybody who's clinically extremely vulnerable. So it's quite timely that these questions were being asked anyway. And I wonder if you could comment on that. Thanks.
Well, the answer is vitamin D is good for you. And actually within kidney medicine, we have been recommending that everyone who has advanced kidney disease, whether they're a transplant or hemodialysis patient, should have their native vitamin D levels, what we call repleted. They should be made up to the normal level because you're often vitamin D deficient. So the answer is yes, it's good for you. Anyway, for a lot of reasons, and indeed it may help you immune system in terms of resisting infection. Just one little caveat. First of all, there is something called active vitamin D that we use in kidney medicine. This includes things like calcitriol and alpha calcidol. That is subtly different from what we call natural vitamin D. And you can be on alpha calcidol and still have low levels of natural vitamin D. And secondly, please remember that your renal units may already have put you on vitamin D supplements. You may not even appreciate it. You may be on something called AdCal, and I see there's a question about that, which is got a vitamin D in it. So what I would advise you to do is before you take these three tablets that are being dished out, just check with your hemodialysis or your kidney team as to what you're on now and whether it is therefore safe for you to take these supplements. But generally, you should all ensure that you are on some form of vitamin D, native vitamin D. They're very cheap, they're very easy to consume, there's no side effects, but just make sure that you're not already on it and it's appropriate for you. You're on.
Yes,
Now you're on.
I've done the ridiculous thing of putting myself on mute, which is anyway. And there's another question, and I think that was about this applies to any of the drugs you might be given on a kidney unit, doesn't it? The same comments apply. So cholecalciferol, I can't say it properly.
Cholecalciferol is a name for one of the names for natural vitamin D. So so unfortunately, in medicine we confuse things by using lots of different names that hide the same drug.
Right. Okay. And there's a question that's come up, and I think it's about something I referred to earlier, which was in one of my questions, which was about something called a cytokine storm, which is a reaction that people have in their immune system to COVID. And I wonder if you could, just for the benefit of everybody, explain what that is, Andrew.
So this was something that was recognized to occur from very early in the pandemic, which was that people became unwell. They went through a stage, first of all, where they had no symptoms and the virus was growing. Then they come to the point where they develop symptoms, if they're going to get symptoms, which would be variable, but include fever, muscle pains, tiredness, loss of smell and taste. And they would have what we would call this sort of flu-like illness. They'd have this flu-like illness for a period of time, and that would vary, but maybe 4 to 7 days. As they went into this illness, there was then a subgroup who didn't just have the flu-like illness, but who got a pneumonic illness. They got a pneumonia. Their breathing became difficult. They're breathless. Their oxygen levels dropped, and essentially they got an infection in their lungs. Many of these patients were admitted, And within that subgroup was another subgroup who went on to the next level, where they got what they call the cytokine storm. And no one quite understands why the virus and how the virus elicits it, but it's where the virus just suddenly elicits a response from the body, that the body releases all of the factors within there from there, your cells that are meant to be protecting you, into the blood, that affect the blood circulation, blood vessels, affect the way fluids move between blood vessels and into the tissues. And this so-called cytokine storm that can be stimulated in a very small percentage of people with COVID-19 causes very, very significant and severe illness. And that's what we were seeing in patients on intensive care units, particularly in the earlier period of the pandemic. And that is a concern, but want to remember that to get to the level of cytokine storm, you've had to gone to getting infected. You may be asymptomatic. You may just have the flu-like illness. You may just have the respiratory illness. You may then go on to get cytokine storm, but it's at the end of a lot of maybes. So most people move out at each of those levels and either don't go any further.
Right, so thank you. So despite the press talking about it quite a lot, it is a very rare complication. So
it's not, if you're looking on intensive care units, it's not rare, but if you're looking at the people who've got COVID, yes, it is rare.
Okay, and one final question about vitamin D. For people with transplants, that's also something that would be helpful to us, is it?
Well, again, the answer is the international guidelines say you should have your natural vitamin D levels made up to normal. Some units have some reticence about doing that in the first year after transplant because it does improve your immune system, and there's a theoretical concern about it. Many units actually still give vitamin D. So if you're a transplant patient and you're in your first year, please check with your unit and your consultant. If you are a long-standing transplant patient, I would strongly advise you to ensure that your vitamin D levels have been brought up to good levels.
And as ever, check with your consultants, your team, because they know you the best. Right, we now need to move on because there's a lot of questions there, but we've also had a lot of questions about the vaccines. And I wonder if we could just pop onto the next slide, Julie. This is a very, all we have on here is 5 or 6 slides for those of you who, words, for those of you who aren't able to see this. Because you're listening on your phone, and they are really around answering some of your questions on vaccinations, and there'll be a range of things about the trials that are going on, the efficacy, the safety, the logistics, and a bit about access as well. So I'm going to invite Richard to take the floor, please, and just give us a bit of a general introduction and talk to us a bit about the trials so far as well. Thanks, Richard, over to you.
Thanks. So, I mean, vaccines are one of the most amazing things about modern medicine over the past several decades. Vaccines are what have eradicated some very severe diseases and made other unpleasant diseases something which are very rarely seen now. So, although none of us enjoy having vaccines because they usually involve needles, they have had a huge public health benefit. And what's incredible about the response to COVID-19 has been that from a disease which was unheard of in January, we're now in a position where we're about to start vaccinating people, which shows us that the development of this vaccine has gone at an incredible pace. And I think that understandably makes some people worried that corners have been cut, that checks that should have been made have not been made. And I think one of the first things to say about the development of the vaccine is that corners have not been cut. There are government regulatory agencies. In the UK, we call them the MHRA. You'll probably hear more about them in the news in the coming weeks. But they stipulate things that vaccine manufacturers or scientists developing vaccines, they stipulate what tests must be done and what results they want to see before they will give a vaccine a license. In other words, before they will let it be used on people like you and me. And they haven't cut any corners, but what they have done is they have tried to work more in parallel with the developers to help them speed up their processes. So that usually what would happen is that somebody wanting to develop a vaccine might do a bit of work, submit it to the regulator to see what they think of it, wait for their response, and then when they get the response, start planning their next bit of work. And that toing and froing of information is part of the reason that it takes several years normally to develop a vaccine. What's happened in COVID, though, is that everybody's recognized the urgent need for a vaccine, and the regulators and the companies and the scientists developing the vaccines have worked a lot more in harmony with each other, so that as much has been done in as parallel as possible, and all of that review time has been kept as short as possible. It's not to say that this is how it's always going to be and how it always should be, but in a global emergency like this, it allows things to proceed as quickly as possible, but while maintaining the highest standards of safety. So I would not be deterred by the fact that these vaccines have been developed quickly, as to suggest that they're in some ways improperly developed. I think that tens of thousands of people around the world, probably hundreds of thousands of people around the world, have gone into trials of these vaccines now, which make them just as well tested as many of the other vaccines that we all receive every year. So when we look at the vaccines, we've heard 3 positive results from a vaccine made by a company called Pfizer, one made by a company called Moderna, and one made by a collaboration between Oxford University and AstraZeneca. And what's really exciting is that all of these vaccines have shown to be effective. You'll hear numbers in the press about, say, the Pfizer vaccine, which is supposedly 95% effective. And what that means is that when they compared the 2 groups, if 100 people would have got infected with COVID, giving them the vaccine meant that only 5 of them did. So 95% of them were spared getting the infection, and only 5% did. So that's what we mean by 95% effective. And we hear that the Oxford vaccine is 70% effective. And that you might think then that the Oxford one's not as good. And I do work in Oxford, but I'm not saying this just because I'm biased. But the important thing about the Oxford vaccine is that although some people still got infected, none of the people who got infected got severely ill. None of them needed to go into hospital. So the really good news about the Oxford vaccine is that it stops people getting severely ill. Some people will get infected, but it seems that they won't end up needing hospital, which is really important. And the advantage of the Oxford vaccine is it's much easier for a health system to manage, because the other vaccines, unfortunately, have to be transported everywhere at -80 degrees Celsius, which is a bit of a logistical challenge, whereas the Oxford one's a lot more simple. The other good news seems to be that age doesn't seem to affect how well the vaccine works, as far as we can tell at this stage. Older people seem to mount just as good an immune response to the vaccine as younger people. So that's really good news too. Do we know about kidney patients? And obviously a lot of the questions here about, do we know what will happen? Were kidney patients included in these trials? Do we know how they will respond to the vaccine? Unfortunately, kidney patients by and large were not included in these vaccine trials, because they always start with the general population, and severe kidney disease especially is quite rare in the general population. So kidney disease patients haven't been included in these early trials. Will kidney patients respond as well to the vaccine as other patients do? I expect the answer here is just like it is for the flu jab, or just like it is for the pneumococcal jab. The answer is maybe not quite as well, but still well enough to make it very worthwhile having the vaccination. So I think that is really important to consider, that we don't have any good reason to think that kidney patients won't respond in a helpful way, even if they don't respond quite as well as normal patients. And because kidney patients are at slightly higher risk should they get the infection, it actually makes it all the more important for kidney patients to have that vaccine. So that's probably what I wanted to say about efficacy. And then we get a lot of questions about safety. And there are some questions we just can't answer, because these vaccines have only been around for a little while. You could ask me, what are the long-term effects of having a COVID vaccine? And I have to put my hand up and say, I honestly don't know. But again, with all of the other vaccines that are around, we don't always get long-term information on their safety either. So I don't think this puts the COVID vaccines in such a different position. But it is clearly something that we're all going to be watching very carefully. In terms of safety for transplant patients in particular, well, we know there are some vaccines which transplant patients can't have. We know that they shouldn't have live vaccines because if your immune system's weakened, you might not be able to fight off even the live vaccine. But the good news is that none of the vaccines so far for COVID are live vaccines. They all work in slightly different ways, but none of them are live vaccines, so they can all be given to transplant patients. And then a very common question that we've had is, well, will having this vaccine make my kidney reject? And I think there's a theory that when you have a vaccine, it stimulates your immune system. And if your immune system gets stimulated, it might attack your transplant in a sort of, as a, if you like, a side effect or an innocent bystander. But we don't have any evidence that really happens with the other vaccines that we give, like the flu jab or the pneumococcal jab. We would always recommend them for transplant patients. We find no evidence that they cause this unhappy side effect. So I don't think there's any real reason to think that these COVID vaccines would be any different. So I think I would not let fear of rejection prevent you from having one of these vaccinations. I think that would be putting things in the wrong order. I think it'd be much more important to have the vaccine to keep you well, stop you from getting infected, than it would be to be concerned about a theoretical risk of rejection. So I think I'll probably said enough in one go there, Fiona.
There's a lot there. Thank you. There's an awful lot there, and thank you for your honesty. Thank you for sharing that with all of us, because there were, as you saw, there were so many questions about this, and I think by summarising the risk to us from COVID and the work that's being done with vaccines so far, you've made a very clear painted a very clear picture of why it's important for us as kidney patients to know about the vaccines, to be offered the choice of receiving those vaccines, and also, is it reasonable to say that this is developing as we go along? So we'll be able to share. I mean, we, the community, I don't just mean us at the charity, to share everything we learn as we progress through this, in the way that we've been able to show the developments in the treatment for COVID-19 as well as we go through. Is it just a couple of questions I just want to just bring up that have come up here? Was there any particular analysis of the BAME population in any of the trials that we've done so far that you're aware of?
As far as I'm aware, there are different sorts of results you can get from trials of vaccines. The earlier results that come out where they measure how well your immune system has responded, like how many antibodies have you produced, and things like that. I don't believe that they found evidence that people from different ethnic groups respond differently at that level. The other sorts of results you get from vaccine trials, which are the ones we're hearing more recently, which are in a way the more exciting results, which is, do they actually stop you getting unwell? There haven't been enough people actually getting unwell in those trials yet to be able to work out whether any ethnic groups respond differently in that way from each other. So I think at the moment the answer is probably there's no clear evidence that there's any difference. So it doesn't really matter what ethnic group you're from. Having the vaccine is likely to work, and almost certainly the right thing to do.
Thank you. So a couple of other things. Does the vaccine interfere with any of the medications? I don't think you mentioned that earlier.
No, there's no reason why it should, and there's no evidence that it does. So I think it shouldn't matter what you're on, the vaccine should be okay. But if you're on any, obviously your doctors would advise you about that if there was anything to be concerned about.
Right, okay, thank you. And somebody has asked about T cells being reduced as part of the anti-rejection medications, and whether that has any interaction with the vaccine that you know of.
So for transplant patients who are on immunosuppression, obviously you might not respond quite as well to the vaccine as people not on immunosuppression, because unfortunately the immunosuppression we use for kidney transplants is a bit of a blunt tool, and it stops you from responding to any infection or any vaccine quite as well as you might have done. That said, we still recommend that transplant patients have their flu jab, because we know that it's better to have it than not, and so forth. So I think it would definitely be worthwhile having the COVID vaccine as a transplant patient. Even if you didn't respond quite as well, the partial protection it would give you would stand you in better stead than nothing at all.
Okay, thank you. And then there's a couple of people who've come through with different conditions like IgA, vasculitis, and so some of the other kidney diseases. Is there anything we can say about the impact of the vaccine on those people?
Nothing specific yet, but I'm not sure I could think of a reason why I would think people with IgA would be better off or worse off than anybody else from having the vaccine. I don't think we've got any evidence that other vaccines cause problems with IgA. They don't cause a flare or anything, or for any of the other conditions. So I think that would be, I don't think that should be wouldn't be material to the decision. I think one thing I would just say, I can see one question about, could the virus mutate to get around the vaccine? And that's a really good question. The answer is yes, it could, but we deal with this every year. Every year, a new flu jab comes out because we know that the strain of flu that is in circulation changes. So every year the flu jab is changed, and that's why we all need to have another one every year to make sure that we're up to date with it. And it may be that's the same with coronavirus, is that the vaccine might be what it is this year, but if the virus does mutate, then we have a slightly different jab when we have our top up next year, because it may well be that we have to have top ups for this vaccine, just as we have to have top ups for the flu.
And just as we, particularly as kidney patients, have to have additional top ups for the pneumonia
True.
vaccine as well, because it still works for us, but it doesn't work in the way it works for normal people.
No, the protection doesn't last long.
Yeah, so it doesn't last as long. And so is your understanding that this would be a pretty similar thing in this set of vaccines as well?
I don't think we know about how long this vaccine lasts for, but there's two slightly different questions there. How long does the vaccine last for, and how long does the virus change at all? And I think it may well be that we need to have top ups, but I think that's one thing we'll find out in the long term, is we will find out whether the virus changes or not, and we'll find out how long the vaccine lasts for. What we know for the moment is that it's at least effective, at least for several months, and that's more than enough to get us through a winter. But what we'll need to find out is whether we then need a top up at the start of the next winter.
And that all the hundreds of thousands of people who've gone through the trials so far, who have had the vaccine, even though a small number of them did get COVID, their outcomes were very, very positive. They actually had a very good outcome from COVID. They weren't seriously ill at all from it.
Absolutely. And I will be, as soon as somebody offers me a COVID jab, I will be first in the queue. So okay. I'd encourage all my patients to be the same.
Right. And there was one other question I wanted to ask you before handing back to Andrew, because I know you've done a lot of talking here. There was a report on the BBC website recently about a further trial for people who do have low immune systems. And it was just really, we had a few questions through to say, is that because we don't think it's going to work for kidney patients? And I think what you've said is there is no evidence to say that it will not. There's absolutely nothing to say it won't work for kidney patients and that it is safe there. But actually, if you could just comment on that small trial.
Yeah, so that's actually, we're actually testing that drug in our recovery trial as well. When you get a vaccine, the point of giving it to you is that it triggers your body to develop an immune response, and part of that immune response are antibodies. And it's actually possible, and it's been done, that some scientists have now identified the antibodies that get produced, and they can produce them effectively in a factory, so that you can give people the antibodies rather than having to go through the whole vaccine thing. The vaccines are usually better because they last longer. And if you give somebody antibodies, they'll last for a few months, but eventually they fade away. Whereas a vaccine might have a longer effect. But there are some people with immune systems that really aren't working very well, who might, if they didn't respond to the vaccine, might benefit from having some extra antibodies sort of given as top up. I should imagine this wouldn't become the standard for most kidney patients, because I expect that they will respond to the vaccine, and if you can respond to a vaccine, it's better. But there are, as they said on the BBC, there are these other purified antibody treatments which might become available for the minority of people who just really aren't going to be able to respond to a vaccine. But it's probably not going to be sort of treatment for everybody.
So that's good to know. Thank you. Can I now just go back to Andrew Frankel for for just a few sort of briefer things, perhaps, because I know time is moving on and there are so many questions for people. But don't forget, you can watch back on this as well if you've missed something, because some of you are asking questions that we have discussed already. So you can listen back on some of those as well. So just a few questions about logistics and access, really. So we've been asked, do we know if any people will have a choice of vaccine? Do we know if any of them will be particularly recommended for kidney patients? I wonder if you could just comment on that, please, Andrew.
So, Fiona, the vaccines will come online. Different vaccines will appear at different times. The stronger I think Rich has already said, there's no evidence that one vaccine is going to be more advantageous or disadvantageous to any of our patient groups. And so the answer should be, as soon as a vaccine appears in your vicinity, take it. Get the vaccine that's available to you. Don't try and play a game where, well, I think I'd prefer this vaccine rather than that vaccine, because you'll end up having a greater period of time when you are vulnerable. If you're offered a vaccine, take it.
Well, I'm planning to, but
And me.
as soon as it's available, of course, under guidance from my kidney unit. So okay, and so I guess, is it likely to come into? So it's nothing to do with cost at all, is it? Someone asked about cost. It's to do with when it's available in your area.
Yeah, absolutely, and there will be differences in costs between the vaccine, but actually that's irrelevant. They're all effective. Although the ones that we're talking about, the ones that we'll be using, just get on and make sure that someone gives you a vaccine.
Okay, and another question that's come up, and I guess we're talking a little bit about priorities and things as well. So we'll be contacted, will we? We'll hear from our units when we have an invitation to take up the vaccine, whether we're with advanced kidney disease.
Yeah, you'll be hearing from your units or from your general practitioner. As you know, there's a debate about the priority and the order in which people are going to be vaccinated. And that's sort of slightly a moving feast at the moment, because that is changing week by week. Age, I think, is going to still be one of the predominant factors that will determine your place in the vaccine queue. But being a kidney dialysis patient or a transplant patient, my understanding is that there's been a change in the prioritization. That group is moving up in the order.
Yes, we saw that as well this weekend. We shared it on social media. So clinically extremely vulnerable people were previously, if there's a chart, they were listed at number 6 in terms of the priority for the rollout. We've been promoted to number 4, and clinically vulnerable people who aren't picked up through age, so that people with an earlier stage of CKD 3 or 4 will be picked up at number 6. That's all provisional at the moment, and I don't know, Richard, if you want to say anything about that as well. But this is the guidance that's based, this is provisional guidance, which will be confirmed in due course. And of course, that also depends on availability of the vaccines, as just discussed. Andrew, just a couple of other things that, just to make sure I haven't missed out here. Do we believe that, I've seen it in the guidance there as well, but several people have asked me about family members. So will family members, just as they do with the flu jab, will they be able to access the vaccines as well in good time? Because of course,
the individuals, I've got a feeling that my guess is actually that kidney patients are going to be are going to do well in this, and I think there'll be a recognition that they need to be vaccinated. They need to be vaccinated early, and I think there'll be a lot of reasons why people, particularly on dialysis units, will be able to get vaccinated early, because the systems will be there. You'll be able to do that on the unit. In terms of other family members, I don't believe at the moment that you're going to be able to carry them with you when you get your vaccination, and they will have to wait until they are called by their GP, or if they have other health issues, of course, they will fit into that group. But no, I don't think there's a plan, as far as I'm aware, for there to be family vaccinations on the basis of this list.
Okay, thank you. Although I think I did see in the provisional guidance that there was a recognition of the need to do that, so they wouldn't follow on incredibly late. That's the guidance, the provisional guidance that we saw on Friday.
Sorry, then I may be mistaken there, but I think that logistically could make the vaccination of kidney patients slightly more complicated.
Yeah. So fair enough. So, and I think that's right. But I think you're right. I think that would have to be through different routes, so through the
Yeah.
GP route rather than through another route. And Richard, if you agree with this or just have any other comments, just jump in here at this point. That would be grand. But another one before I move back to Richard. There was just something about monitoring of patients after receiving the vaccine, and any blood tests being carried out, and whether you believe there'll be any sort of any monitoring and follow up of that.
Well, there's no monitoring now when you've had your flu jab or your hepatitis B jab, or whether you've had your pneumococcal vaccine, and I doubt there will be any formal monitoring. We will not be looking to see whether you develop antibodies. We know how successful these vaccines are. There may be a little bit of curiosity to make sure that you do have booked a kidney blood test if you're a transplant patient within a period of time, but I don't think there's going to be any formal monitoring process. This will be like any other vaccine that we currently administer to transplant and dialysis patients.
Okay, lovely, thank you. And there are lots more questions that are coming up here, and we'll try and address some of those at the end. Although obviously time, perhaps we're going to take probably about another 10 minutes longer than we're scheduled for the hour, because of the volume of questions that are there. And I hope everybody who's listening will be able to hang on for a few more minutes. We try and hoover up a few more of your questions, because they're coming through thick and fast. And thank you for that very much. I think probably I could invite Richard to take the floor now, and it's just a little bit about how we learn to live after the vaccines start to be rolled out. Where we've talked a lot about safety, you've talked a lot about efficacy and the need and the sort of risk versus benefit of us having those vaccines, just as we do the other vaccines that help to keep us well. And I wonder, just in terms of, as the vaccines start to roll out, mixing with other people, what are your thoughts on when you see that might be able to happen, and the care that we as kidney patients will have to continue to take for a period of time? Because this is about learning to live at some point in the not too distant future, we hope, in a world where COVID now exists, just as pneumonia exists, just as flu exists.
So I think that's a really important point, Fiona. So I don't think the vaccine is not going to wipe out COVID. COVID is probably going to stay, just like flu. And we'll just have to remember to have our vaccines every year. But I don't think that's anything to be frightened of. It's just another one of the viruses that will be around, particularly at wintertime. And that said, we all know how to look after ourselves when it comes to flu and those other common things. We know, as transplant patients, we all know the importance of washing hands. It just highlights that really, and other methods, things that we can do to keep ourselves safe. In terms of how we get from where we are now, obviously currently just coming to the end of a lockdown, probably at one extreme, all the way through to what we hope will be life back to normal, as Fiona says, in the not too distant future, is we're not going to wake up one morning and everything be fine, having it been a problem the night before. This is going to be a gradual change across as the vaccine gets rolled out across the country. So I think probably until you've had your vaccine, I don't think people should do anything differently to what they're currently doing at the moment. They should still take all the precautions that they're currently doing. But I would also say that once you've had your vaccine, that doesn't automatically make you invincible, and I wouldn't immediately change your behaviour. But I would probably wait until we see infection rates in the community falling down, as they will do next year, especially as the weather improves, and as a higher proportion of the people get vaccinated, such that how common the disease in the community then becomes very low. And when that happens, then essentially we will know that it's probably safe to return to life, as we previously described it as normal. Once we know that infection rates are very low in the community, then the chances of you picking it up will be very low, and I think then life will be back to normal. But that is going to take some time, but hopefully with an effective vaccine and getting it rolled out at the end of this year and into next year, that may well be the case during the year at some point next year. But we'll just have to wait and see how quickly we can get all of this rolled out. But I reckon personally, if I was to bet on it, I would reckon that next Christmas will be a lot more fun than this one.
Yes, and we'll talk about Christmas very briefly at the end as well. I think just people are very impatient. They've had a horrible year. Kidney patients, have had, along with many others, had a particularly challenging 9 months. So people want to get to the end of it, but this is a way to get to the end of it, as far as I can see. And I think at that point, would we be able to sort of start to resume working in the office a lot more? That would mean that as well, I guess.
I think because once the infection rates are down and under control, the chances of your office mates being in an infection risk you'll be very low. And so, yes, you could reasonably get out there and get back to work.
Brilliant. Yeah. And just a couple of really quick, short things, actually. But in terms of the vaccine itself, I understand that there would be two doses given with a gap in between. Could you just briefly touch on how you believe that would work for us, and what the gap would be between the two?
I think it depends. That depends on the vaccine that you get. As Andrew said, there are a few vaccine. There's the main two vaccines at the moment you might get either is the Pfizer or the Oxford vaccine, and I think the dosing schedule for them slightly differs as to whether you need your jabs 3 or 4 weeks apart. But you'll be told, once you've had your first one, you'll be told when to come back for your next one.
Right. So a gap between the two anyway, and two doses. Right. Okay. Thank you. Now we were just talking about employment. We did have a few other questions about employment, not specifically around the vaccine, but if I could ask Andrew just to come back on again, just to talk a little bit more about that. As we were just talking about employment anyway, and it's back to the sort of risks and benefits of going out to work. And I know we touched on this earlier. We talked about risk, and it is of course people's choice as to whether they carry on working or not. And I wonder whether you could just comment on that, because some people have told us that it does make them feel very depressed, not feeling able or not being able to go back to work, and others. And we've heard so much from teachers and other people who work at school through this time, and other people in public facing roles. So just, because we do have a period of time where this is going on, and of course we do have to keep vigilant because we're not out of this yet. And I wonder, Andrew, you could give some advice to people.
Well, my advice probably hasn't changed much since the summer. And remember, there's two parts to this. One is your own personal risk, and that comes back to all of the issues that I defined at the start of this webinar. And the second is the job that you do and how you get there, because that will also determine whether it's safe for you to go back to work. You have to put those two risks together. Remember, on top of that is the mandatory. So there's whether or not you're, at the moment we are still officially in what's called lockdown, and you should be working from home if you can. And if you are extremely vulnerable, you should continue to work from home if you can. If, however, you gauge your risk as to be less than extremely vulnerable, just vulnerable, and you think that the work you are undertaking can be delivered at an office-based environment safely because you've had that risk assessment discussion with your employer, then that's reasonable to go ahead and do that. But if you do, be careful with social distancing, frequent hand washing, all of those things that we have talked about, which anyway you're going to have to do irrespective. So I think you have to balance those two things in order to determine what is best for you. What is important is that if you believe yourself to be extremely vulnerable and your work environment not to be safe, and you are finding it difficult to engage your employer, you can and should, and indeed your nephrology team, your dialysis team or your transplant team should be there to support you. And that should be more than just a generic letter if you are in big trouble. There's only occasional patients who fall between those holes and find themselves in that position. But I would really hope that their units would be there supporting them in that situation.
Thank you. That's a really important point to make. We have heard from people that our advocacy service, our advocacy officers are there to help you if you fall into those really difficult situations. And I probably wouldn't be doing my job in policy not to also mention the fact that we have been campaigning on that issue, so people are appropriately supported to continue to work from home, to be given, because furlough is now available to the end of March, which is helpful. That was only confirmed recently. And as the various advice on sort of various lockdowns and different tiers and things come back into play in England. In fact, in all the countries of the United Kingdom, the message really is, of course, to continue to take care. And if you want to let us know that you need any support on any of those things, of course, do let us know, and we will help, because that helps us to raise the parliamentary questions and the other things with the policymakers as well that we do report on our website. So do keep your eyes on our website as those things develop. And if you want to let us know or ask us questions about that, that's one of the things that Kidney Care UK is there for. Now, I just would like to ask you, Andrew, a further question that's come up, quite an important question actually, and also Richard, actually, you may wish to comment on this, because I'm going to invite you in before the end today. And it's really about fake news, social media, being as clear as we can with what we know, and to act as, in your advice, I suppose, on how we can be as clear as possible with the facts, so that people aren't misled around, all sorts of theories that may not be fact-based, and are able to get that information on which to make their decisions on going forward with vaccination and the way in which they behave, because we do know there's a lot of stuff swirling out there at the moment.
Well, actually, the answer to this is very simple. I'm not a Twitter user. I'm sort of grey-haired, but I do appreciate many of you are social media users. I would really urge caution in terms of looking at information that you read about in the newspaper, that you see on social media. And one of the things you've actually got is a wealth of potential resources where you can get information that has been properly assessed and properly written out and presented. And that's on, Fiona, on your website, on the Renal Association website, the BRS website. That is where you will find the information that tells you, gives you the facts as the evidence supports it. And I would be very, read these things. We all read all of this thing on Twitter, and, we discover, I don't know, baked beans is the cure for COVID if you rub it on your chest or something. I don't know. Wherever you read, you find the facts on Kidney Care UK, on the Renal Association, on the BRS website. That's where you really need to go to get your information.
Thank you. And I'd also encourage people to keep asking us those questions, so we can ask our medical colleagues who we meet with very regularly, especially over these last few months on all of this. And I'd like to now just thank you, Andrew. That's been incredibly helpful, and we've had some really positive comments from everybody. I'd like to go back to Richard Haynes, if I may, just for a couple of other things before as we are now slightly over time, we're heading towards the end of the webinar. Thanks everybody most people for staying on. It was just really, just to say, is there anything that you'd like to talk to people about with regard to Christmas? Because obviously it's a time of year that's going to be different to other Christmases we've had before. A lot of kidney patients have been talking about this on our website. And any advice you'd like to give people about keeping safe, especially as it's been 9 months. It's tough. There's some new government guidance, but that doesn't change our extreme vulnerability to poor outcomes if we catch COVID.
Yeah, I don't want to sound like the Scrooge here, but I think this Christmas is going to be different for people. I mean, so many kidney patients have done such a fantastic job of looking after themselves or their loved ones over the last 9 months. And it's really not worth putting it at risk for Christmas, I'm afraid. I think the government have outlined some things that people can do where they won't break the law, but I don't think that's the same thing as them saying what they should do. And I think for people with kidney disease, particularly dialysis and transplant patients, it would be wise this year to plan for a socially distanced Christmas just with your usual household, and not take any what would, I'm afraid, be unnecessary risks about mixing households. Now that's not, everybody's circumstances are slightly different, but by and large, I don't think I'm afraid, this is a cliche because you've heard it said on the news and things, but the virus doesn't know it's Christmas. So I'm afraid it will infect you at Christmas just like it would on any other day of the year. So I wouldn't take any untoward risks for Christmas this year. What we're doing in our family is we're saving things up, and we're just going to make it all a lot more fun for next year.
Yeah. Thank you. And I'm sorry to make you the Grinch there, but I know a lot of people have been talking about that on our Facebook group and in other places as well. I mean, I think we have, everybody listening and so many others, you have done all incredibly well this year. I know that people have had to be very, very, very brave and have had to endure an awful lot, and that's been very difficult for everybody. But we'll be having a very, very, very small Christmas ourselves as well, and I guess that's just looking forward to a better time, in the summer as well. So yeah, there we are. But thank you for saying that. And I wonder if, Julie, if you could just go on to the final slide, and I just would like to invite Becky as well. If there's anything, Becky, that you think we've missed out on, that you think we need to say before we finish off, or if Andrew also has anything that they think we need to say, well, I start to finish off. Are there any unanswered questions? Because Dr. Suckling has been zooming through and just literally asking. I can see she's answered 59 questions, or possibly a couple of other colleagues have answered those as well, which is pretty good. While trying to
it's just me answering. So I think one of the questions is around people who have the vaccine with transplant or kidney disease may not be as have the same response as healthy people. But I wondered if Richard could just talk a bit about the whole process of vaccination. It's really about the population, and getting the amount of virus in the population down will help us all, and healthy people getting vaccinated and different groups of people getting vaccinated will make all of our risks lower. I just wondered if Richard could pick that up, because that's coming through quite a lot on the question.
Thanks, Becky. Yeah, I'm sure. So this is the famous phrase that you might have heard earlier, which is herd immunity, which isn't isn't the greatest compliment we can pay each other. But Becky's quite right that if a large enough section of the population have the vaccine, then the virus has nowhere to go, and that makes it safe for everybody. So I think even if kidney patients don't respond quite as well, as it doesn't matter, because if all of your family and friends around you had the vaccine, the virus just has nowhere to go, so it becomes a much rarer disease. So don't worry about your individual response so much. It's what happens in the population, as Becky says.
Just one more thing. I think a lot of the transplant community and the community of people with vasculitis, I can see from the webinar, are worried about whether vaccines will lead to a flare. I know that was slightly answered within the webinar, but I'm still getting questions through. So what I'd say is it's probably worth having a chat with your own kidney doctor around that, and just running through your risks, because COVID-19, if there is a vaccine available, your risks from that, if you do pick it up, are high. So it is really important to have a really good discussion with your kidney team before you make a decision about whether or not you want to take the vaccine. And I'm sure everyone's kidney doctors would be happy to do that, but it is important just to have that discussion and work through your personal risks and your worries around your own disease. It would be my advice.
Thank you. That's excellent advice, on which I will start to close the webinar down. Just as a reminder, because some of the questions have come back up again, if you missed them earlier, this talk is available, will be available on YouTube with there'll be some subtitles on there as well, and we'll let you know when that's available. There'll be a report from this as well, which each of our medical colleagues will have oversight into and input into as well. We'll be giving a very short follow-up survey for those of you who want to let us know what you thought of this and whether we should keep doing things like this. And a reminder that we are continuing and will continue to update information for patients, with support from our medical colleagues, absolutely, at Kidney Care, www.kidneycareuk.org/coronavirus. That's the place to go and look. And as everybody has said, for personal medical questions, and if you're worried about these things, please talk to your kidney team. But if you need any general support, our advocacy team is there to help you. Our counselling team is there to help you. And we also, of course, we can offer financial support as well if that's something that you need. So I know there was a comment at the beginning about people not necessarily knowing about this event. You can sign up to our website, go into Contact Us and sign up to receive our newsletters. So you'll get information about any of these and other events that we do. Also, the Keep Your Distance badge that those of you who are watching this live will be able to see. It's an orange, it's not orange, it's a yellow badge. You're welcome to receive those free of charge. I think we've given away 20,000 of those so far, just as a sign for people to keep their distance. And I'd like to thank all of you for your time, for all the questions that you've asked. And I'd like to give a very, very special thanks to my colleague Julie for doing all the support at the Renal Association, others at the Renal Association, to my own colleagues, to Sharon and Sam, who've been busy working away in the background on this as well. And of course to Dr Andrew Frankel, Professor Richard Haynes and Dr Becky Suckling for all their really hard work in supporting all of us as kidney patients alongside everyone else in the NHS. Wish you all a good evening. Thanks ever so much, and do please keep safe, and see you again soon. Thanks everybody. Bye bye for now. Bye.